But the way you handle politics, they could use you in Washington. Tonight I have the pleasure of doing something I've actually never done before, and that is to introduce my distinguished colleague, Dr. Jim Youker, who's been a dear friend and a productive colleague for 40 years. Jim recruited me to Milwaukee 40 years ago next month, actually. Jim is the Robert C. Olson Professor of Radiology and Chair of the Department of Radiology at the Medical College of Wisconsin, and there he has served in that capacity since 1968. So far as anyone knows, it's the longest term in such office that anyone has ever served, and he's still doing it. Under his aegis, the department has become one of the premier radiology departments in the country, and during its time of operation, its achievements have been very notable. Over 350 residents, fellows, and other trainees have launched their careers in that department, and many have gone on to great achievement of their own. Furthermore, even at the Medical College of Wisconsin, it was his vision and his abilities that launched and spun off from the Department of Radiology two other departments, namely the Department of Radiation Oncology, the Department of Biophysics, and the Imaging Center at the Medical College of Wisconsin. So this is a very notable achievement. And it has not gone unnoticed either on the campus or around the country. And in fact, I dare say there's not a radiologist in the United States that does not know Jim Youker and what he has contributed. For example, in 1989, Jim received the Medical College of Wisconsin Distinguished Service Award, its highest award. In 2008, he received the Distinguished Service Award of the Medical Society of Milwaukee County, and also was made an honorary alumna of the Medical College of Wisconsin in that same year. He has been the recipient of 4 gold medals of the professional societies with which he has been engaged, including the American College of Radiology, the Radiological Society of North America, the American Röntgen Ray Society, and the the Association of University Radiologists. I would just summarize that level of recognition as saying there aren't any others. So this has been a total manifestation of the respect in which he is held. On a personal level, I think everyone in the room knows him and knows what a fine individual he is, known for his honesty and gregariousness. Someone said, meeting Jim Youker is like opening a bottle of champagne, but getting to know him is like drinking it. And I think that's decidedly true. So Jim, congratulations on behalf of everyone here.
Where do you want us to stand?
Over here.
Oh, there we go. There we go.
There we go.
I'm going to read it to you back. Sure you want to be present? The plaque reads, in recognition of outstanding contributions to the advancement of knowledge and practice of medicine by a Wisconsin physician. Congratulations
Thanks so
again.
much.
And just to keep all the bureaucrats happy, neither Dr. Youker nor I nor any members of the planning committee have any financial disclaimer. In any event, you understand it, and the bureaucrats will too.
Interesting how things have changed, haven't they? Well, thank you so much. It's a truly great honor. I'm moved when I know how many other really outstanding members of this community have received this award, so thank you very much. And thanks for your kind remarks. I'm very appreciative. I think probably the best thing I ever did here was to recruit Frank. And Frank told me a few minutes ago that after this 40 years, this is the first really nice autumn. I've been promising him a nice autumn. This is the first one I got. So, what I wanted to do tonight was to talk a little bit about our experience here with medical imaging. And I didn't want to just go through a bunch of facts, but I wanted to talk about how people in this community and institutions have been involved. It's been an exciting time in imaging, and I thought some personal notes would be more interesting than just some facts. So the topic is medical imaging, past, present, and future. And I must say that I didn't predict what the present would be, so I think my ability to predict the future is probably just about as accurate. So this whole thing started with Conrad Wilhelm Röntgen in November 1895. That's our holy day, November 8th. He was working with a Crookes tube, which they were using to study cathode rays. And he happened to be having this thing turned on and got a picture of his wife's hand in front of a photographic plate. So that's how the whole thing started. He was smart enough to recognize that there was some other kind of ray. Now, what people didn't recognize is what these other rays could do. And the Crookes tube, which was widely used, they were all over the place, many of them in the United States. What happened is that people would figure out if it was good enough by putting their hand on it to warm it up. And as a consequence, people ended up being martyrs to the specialty because they lost their hands and often their lives. But the interesting thing about it, since everybody had Crookes tubes, it wasn't very long before all around the world people were getting x-rays. Now the next thing that happened that was very important to medical imaging was the use of oral contrast. And Chaiman in 1905 started doing this. And this is interesting. He started with bismuth because he knew that was opaque, but he didn't realize how toxic big doses of bismuth could be. And he had one of his patients die, so he decided to switch to barium. And barium has become the contrast for oral contrast standard ever since. You stop and look at what these guys did, and you realize you couldn't do that today. There's just no way you could do these kind of experimental things. He just looked at the list of things that might be opaque and tried one of them. Well, it's so inconceivable that one could do that today. And so many of these great things probably would have been very difficult to do. Now, the next one was iodinated contrast, which is really our standard now. We live by iodinated contrast. Munoz, a Portuguese neurologist, neurosurgeon in 1927, first did a cerebral angiogram. And he's an interesting fellow, too. He ended up getting the Nobel Prize, but he got the Nobel Prize for doing prefrontal lobotomies, something that wasn't too good. But he recognized that the iodinated contrast had some problems. Patients got sick, they vomited, they didn't like it. So he found another product, a product that had absolutely no side effects whatsoever. Patients tolerated superbly well, a product known as Thorotrast. One of the problems, he didn't realize that Thorotrast was radioactive. And so these patients, after years, developed multiple tumors, particularly in the liver. I autopsied a patient once when I was on a pathology rotation, and you never saw a liver that looked worse with just a series of hepatic tumors throughout. Linear tomography was invented in 1931 by Z.Z. de Plans, a Dutchman. An interesting side story in that, when I was in Sweden, this little fellow came in to the coffee. The Swedes took time to make sure they had some coffee every day. Came in, and one of the Swedish radiologists started to argue with this guy about linear tomography and how it was done. And I think those of us in this room remember linear tomography. Younger people wouldn't remember what it was. But at any rate, they started arguing with the thing. We got all done. I told the guy, I said, "You know who that is?" He had no idea that was the guy who'd originated. It was kind of an embarrassing moment. Well, through the years, we got markedly improved tube screens and film processing. And then in 1953, Seldinger, a Swedish radiologist, developed a percutaneous vascular catheterization technique, which led to tremendous advances in terms of what we could do. Now, it's been recognized, the contributions by the Nobel Prize, and Conrad Wilhelm Röntgen got the very first prize of physics. Cormack and Hounsfeld, who were responsible for the CT, got their prize in '79, and Lauterbur and Mansfield got theirs for the MRI in 2003. So there's been wide recognition of what medical imaging has been able to do. And as I think everybody in the room knows, it has dramatically changed the practice of medicine. So what happened in Milwaukee? I arrived here in '68, back when we had a county hospital, a very good county hospital. There was no such thing as cross-sectional imaging. Radiation therapy and diagnostic radiology and the practice community were combined. We were fortunate to recruit Frank and Jim Cox and got our thing separated. We used barium to study the GI tract. That was how we looked at function. But we're really looking at function. We were looking at the anatomy. We're looking at what the abnormal anatomy did to structures around it. Catheters were used, but largely for diagnosis of vascular disease. And what do you suppose were our biggest accounts at that time, financial accounts? It was Kodak and DuPont, far larger than anything to GE or Siemens or Philips, because film was where the money was. Then what happened? In 1972, at the RSNA, some Englishmen came over and brought a film which had never been seen before. And it's over here on this side. Here we are with a frontal lobe tumor. Now, there was only no way to do that in the past other than something like pneumoencephalography or angiography. And this thing that you're seeing here was the first one in the United States, which was at Mayo Clinic. Now, this in itself is an interesting story because the money that EMI had to let this physicist work on this idea of using attenuation and then finding the data from attenuation at multiple points around the body and then using a computer to reconstruct an image, they let him play with this, and the money all came from the Beatles. It was the Beatles' money that allowed EMI to be able to do this, which led to the first CT scanner. So it started in '72 and used computers to create cross-sectional images. This changed everything. At first it was used in the head. The reason it was used in the head is the head didn't move. The rest of the body was hard to get away from motion. And it now impacts everything we do. One of my residents, one of my faculty now, it's this interesting saying in terms of CT. I don't know the question, but the answer is CT. So that's the extent to which we're now using it. Well, how did it develop and what was our role here? This was a classic example of a symbiotic relationship between industry and a medical specialty, in this case radiology. It would never have happened if industry did it alone. It would never have happened if radiology tried to do it alone. So we got involved with GE. We had been involved with GE testing some of their equipment before because, as you know, they're based here in Waukesha. There was a meeting that GE had when the first scanners came out with a group of about 5 or 6 of us, Bill Haney and myself. We met down in Nassau, and Charlier, who at that time, a Belgian fellow, was head of medical imaging. And we talked to him about how the GE ought to get involved in this. I'm not really sure that that's what we think GE should do. So Welch was smart enough to go ahead and get a new head of the medical division, and they proceeded and moved forward. That meeting in Nassau was interesting because it was in a 6th-floor building in Nassau, hotel, and the top floor was reputed to be owned by Howard Hughes. I guess the whole thing was owned by Howard Hughes. So when Bill Henny and I got in the elevator, somebody pushed 6 by mistake. So we go up. I didn't think we'd get out there. The door opened, and some very large guards were sitting there saying, "I think you guys are on the wrong floor." So what did we do? So we remodeled a ward at County Hospital, one of the old wards. GE did this for us, and put in a ward so we could test the equipment at a place where they could talk about the equipment to people, waiting area, the things. Worked out very well. Now, I have to give credit to one of the former members of this society, John Peterson, the late John Peterson, who was very supportive in this whole effort. Probably wouldn't have happened if he hadn't been able to persuade the county to do it. So each technical advance, each one of these new scanners came out, led to new applications. For example, we were able to be the first people to see herniated intervertebral disc, which did away with the myelograms, which had been a very unpleasant experience to have. And you can now be able to diagnose this entity with just a CT scanner. It's very helpful. Our guys got sorted out papers, and it increased the reputation of our department. So what did this do in terms of changing practice? It did away with things like pneumoencephalography. Now, many of the people in this room are old enough to remember pneumoencephalography, but that was a form of torture. I mean, waterboarding would be nothing compared to being pneumoencephalography. You put the patient in, put some air in, and turn them upside down. You got a bunch of x-rays. It was unbelievably cruel, but it was the only tool they had to be able to see what was going on inside the head. Myelography did away with that. And then very importantly, when's the last time you saw somebody have exploratory surgery? It just doesn't happen anymore, and that was a very common phenomenon. Pulmonary angiography. We've now taken the place of pulmonary angiography. It's faster, more efficient patient care. And a patient recently came in with some abdominal pain and a fever. So that thing in the old days, we would have done a bunch of different films. I had the patient stay in the hospital for a day or two to find out what it was. Instead, we did a CT scan, proved that it was diverticulitis. The patient was treated and was out of the hospital in a matter of hours. Now, what caused these advances? Well, they were driven by available dollars. There were dollars available to go in and do these kinds of studies, to advance this equipment and build it. And industry was making money from it. And so this is one of the reasons we were able to do that. So now, what are the kinds of things that we do now with the more modern ones? You saw the first one. This is the kind of things that we do now with volume. We can actually demonstrate. Here's a, Dudley, you'll recognize this thing. This is a graft going to the anterior descending artery. Here we can see it over here. That kind of an image was impossible in the old days. Here's another similar image. Whoops. Here's a abdominal aneurysm with a leak. Here you can see the leak, and here you can see the whole thing beautifully demonstrated with this edge technique that we used. This is so far beyond what we originally had. Well, there were additional advances. There was magnetic resonance imaging, which allowed us to differentiate soft tissues, and particularly valuable in the head and joints. One of the things that built this thing up is its use in sports medicine. Every time you hear of one of our star players who's injured in the field on Sunday afternoon, the first thing you find out they got is to get an MR. So now anybody who has an injury thinks the first thing they need is an MR. So it has tremendously increased the volumes of that, but I think we're starting to understand that that's not the best way to do things. Diagnostic ultrasound became very important, gives us online diagnosis. Great for looking at the biliary tract, crucial for OBGYN, and we find it very valuable in the breast and allow us to identify structures for biopsy. And then digital imaging has been a very important thing. When we converted from films to the digital formats, allowed us to start to do teleradiology so we can send images from place to place. That has had a little bit of a effect that worries us a little bit because you can now have images sent around, but somebody can do it distant from the hospital. And so we worry a little bit about whether we're going to become a commodity or not, and that's why it's important for the radiologist to be central to this diagnostic stuff and be functioning along with the clinicians. None of these technologies were available in 1968. Cost has become a very big issue, but it was from the very beginning. When we first got our $300,000 EMI scanner, John Doyne, who was county administrator, said, for $300,000, they got to be worth something. You guys had better make this thing work or you're in real trouble. Well, fortunately, we made it work in a big way. But there was a real concern about whether we were going to put in too many of these units. And we ended up with Certificate of Need, which was a method on the part of the state to limit the number of CT scanners. lot of legal money was spent trying to overcome that rule. But I remember one of the certificate of need meetings, there was a guy who was the vice president of Schlitz who was there, who made the statement, you know, these CT scanners are just a plaything for you doctors. Well, you see what happened to Schlitz. So, it's been a tremendous increase in the utilization of imaging, and that has added to cost. So, over the years, the cost of medical imaging has gone up more than anything else in medicine. Now we're seeing shifting public attitudes. We're seeing decreasing reimbursement. Radiologists did very well. People who owned units, often who were not physicians, simply had a unit as an investment, did very well. Those days are done. And so we're seeing flattening out or decreasing of volumes. But I think what's very important, and many people in this room with our other specialties have been involved in this, we have programs to reduce the non-indicated studies. There's just a lot of studies that are not necessary. And I think that's an area where we're going to see continued effort. I know internal medicine has been central in trying to work in that area. We worry about radiology becoming a commodity, about having our images sent to India where they can be interpreted for a fraction of the cost. And what's happening is there's less funding for new developments. Will we have things like CT and the rest of these things develop? I don't know. So here's looking at some of the utilization rates. It's utilization rate for MR, and you can see it's flattening out, which is not surprising. Now CT volumes have stayed up well. You can see each year an increase in the utilization of CT, although I think we're starting to see some changes. I think we're starting to see it flatten out. And I think one of the other things that's been a concern, you can see a list of well-known payment reductions. I won't go over them, but you can see over the last 10 years a series of reductions in reimbursement. Particularly hurts for the reimbursement for the technical side, so that rural areas find it difficult to afford putting in a CT scanner or an MR. So that's going to limit utilization. But the real concern has been over radiation. The public is greatly concerned over radiation. There's articles, which we've all seen in the public press, the New England Journal, predicting an epidemic of cancer coming from CT. The one thing we have to stress is the impact of age. This is a serious problem for the young people. For the people within this room, it's not a problem. You know, getting your teeth x-rayed, don't worry about it. I mean, they'll put a shield on, that's a good idea. But the age is a very big issue. We're getting decision support from industry, so help us with ordering. So when you order, you'll be able to see whether that was a good idea or not. And then there's been a marked reduction by industry in terms of radiation levels. For example, the cardiac exams in the old days were 15 millisieverts, they're down to less than 2 now. So this is a very important reduction. Iterative reconstruction is important, perspective gating, reducing the KV, and I think there's going to be some hesitancy to screen the entire population because of concerns over radiation. Now here you can see what's happened in terms of ionizing radiation and the role of CT. In the early 1980s, there was a relatively small amount of the background radiation came from medical sources. Now you can see in 06 it got up to 48%, and probably is even higher than that now. So this was a legitimate concern, particularly a concern when one looks at age, because we would see young girls in their teens coming in with Crohn's disease and having 4 or 5, 6, 7, 10 CT scans. That did result in a significant amount of radiation. But the young tissues are particularly prone to be damaged from it. The old tissues are not. So as I assured you here, don't worry about your dental x-ray. You can see that the pediatric age group, that the radiation-induced carcinogenesis is much higher, to the point where we now are doing special studies on women who've had radiation therapy of Hodgkin's disease. which does indicate result in some radiation of the breast. We're having to do careful studies of them because they do have an increased incidence. So what's the future? Well, to be honest, I don't know. I didn't know before, I don't know now. I think there's going to be more emphasis on function. We'll get away from straight anatomy, and we'll start to deal more with function. And we have some things that we can use that are going to be helpful. The nanoparticles as carriers attached to various entities, it can be very helpful to us. And there's a whole bunch of research being done in this area, which I think is very exciting. Fluorescent labels, that's particularly been helpful for people who are doing open surgery. Inject a fluorescent label. That's the same stuff that fireflies use. And you can show the edges of the tumor, so it's helpful in doing that. Dual energy can be helpful. Allows us to detect individual materials. MR, the MR is a great future. New protocols, diffusion weighted, iron labels, all of these are very exciting aspects of MR. Focused ultrasound therapy, I think that's going to be a potential area for additional therapy. Ultrasound contrast, that hasn't really caught on yet, but I think as they get past the FDA, there's a great deal of potential for that. What's happened to the changing role of the radiologist? Well, compared to when I got started, this thing has become very different. The radiologist is far more involved clinically than in the old days. In the old days, we simply looked at x-rays in a darkened room. Today, we're involved with patients doing procedures. A large number of the biopsies, bone biopsies are done by radiologists. The breast biopsies are increasingly done by radiologists. Things such as tube placements, we never used to do that. Now radiologists are doing a large number of the tube placement. Abscess drainages, that was nothing that we had a chance to do. And now even venous access. And there's some interesting data on venous access. If you look up here, the radiology is right here. So that increasing amount of venous access is being done by radiologists. It's all surprising me. We used to have a fight for a chance to do this. When I came back from Sweden, Dr. Kuhn down at Medical College of Virginia, even though I had some training in angiography, I refused to let us do anything. That's one of the reasons I left and went out to San Francisco, is because there just was no willingness to let anybody else do it. And now we find that we're doing all of these things. So this change is dramatic, and so that the radiologist's role, I think, is going to be very different than it was in the past. It has been a very interesting time. I can't imagine any specialty where there's been more change and more fun. And so I very much appreciate the opportunity of doing it, being here, and I appreciate the chance of talking to all of you this evening. Thank you so much.